everyone in the room to this meeting of the Health Overview Select Committee. This meeting is being held in person at County Hall and is also being streamed live on the County Council's YouTube channel. A fire alarm test is not expected during the meeting. If the alarm sounds, we must evacuate County Hall. In the event of an emergency, please make your way to the nearest exit and meet at the muster point located in the main car park. So, to the first agenda item, I'm going to ask Megan to provide us with details of any apologies and substitutions.
Thank you, Chair. I have apologies today from Councillor Edward Back, Councillor Richard Price and Councillor Stuart Dark.
Thanks very much. Can I ask members to confirm that they're content with the minutes of the meeting dated the 4th of September and that I can sign these as a true and accurate record of... Show hands? Smashing. Thanks very much. Do members have any interest to declare regarding any item covered on today's agenda? No one. Okay. I'd like to update the committee on my recent visit to the new Community Diagnostic Centre at the Norfolk and Norwich Hospital in my capacity as chair of this committee. It was excellent. It was a quick visit, but the building is incredible. The facilities there are amazing, and if it's an indication of where the health service is going, it's a good place, and they've got a really good cafe there as well. Okay, which is hardly important, but I just thought I'd add it. Thank you. Okay, the first item we have today is histopathology delays. Can I welcome representatives from the Norfolk and Norwich University Hospital? So we have with us Dr. Stuart Williams, Chris Cobb and Stephanie Walker-Ward. Can I ask the representatives that when you first speak that you introduce yourselves and let us know the nature of your job? Thanks. I'd also like to highlight to the committee that the link in paragraph 6.1 on page 14 of the agenda doesn't work. The correct link has been circulated to you and will also be included in the minutes of this meeting. We haven't received any members of the public who have requested to speak on this item. So I'm going to hand over to the Norfolk and Norwich University Hospital's representatives to briefly introduce the report.
Hi there, my name's Stuart Williams. I'm a medical doctor, but I'm not a histopathologist. I'm a radiologist by profession, but I'm responsible medically for the group in which cellular pathology, pathology in general, laboratory medicine, pharmacy, radiology sits within the hospital. So I'm responsible through my medical and managerial colleagues to the hospital for the things that go on in those areas of practice. So the paper that's been submitted by myself and colleagues outlines the problems that we've been experiencing over the last few months regarding delays within the histopathology service. There's a brief overview of histopathology in the document which describes what it is. It covers a wide variety of practice, from the very small biopsies you might have done of your skin or when you have an endoscopy to big surgical specimens and how they're processed through the lab and then reported. And it involves a variety of conditions, some benign and some malignant. Though we're from on our name badges from the Norfolk and Norwich University Hospital, you've got to be aware that the histopathology service covers the entirety of the county through the Eastern Pathology Alliance. So we also serve the JPUH and the QEH. So it's a county-wide three-trust group model, and it predates the group model that Leslie Dwyer was talking about the last time she was here. So the situation is outlined there in terms of its the concerns that we would have about this from a medical management point of view. The 6 points that really look at the reasons why the problem has arisen, which has an element of workforce shortages, additional workload coming through, particular problems regarding sickness in very subspecialty areas such as skin, which we can touch on if you like, and recruitment into posts, and also the upgrade that we've had to the laboratory system, which needed to be done, but like any large IT project, causes a degree of disruption in trying to make things better. And then we've looked at how we can look at the clinical impact, the operational impact, and the performance impact of those things. And really the graph that's on page 19, which is part of the submission that we make to NHS England in terms of their oversight of what we're doing, kind of highlights the trajectory of where we've been and where we hope to go. And you can see that the grey bar on the top is kind of where NHS England would expect us to be in terms of our turnaround of this is particularly focused on the suspected cancer 2-week wait pathway, which I'm guessing that maybe people will be particularly concerned and interested in. So they expect our performance based on agreed criteria to be around where that grey line is at the top. And you can see that this time last year, things were going quite well, but then we had a decline in the service that we offer for the reasons in those 6 points that they're outlined in the paper on the previous page. And then the dotted line at the end is the trajectory that we've signed up to in order to get things back to where they were and to be providing a service that we would feel more comfortable with. And the paper also outlines the measures that we put in place in order to try and achieve that trajectory. So it's early days in terms of the things we've done, particularly around the recruitment of locums into post, having honorary contract people providing additional workforce for our department on the reporting front, and the development of outsourcing to an external provider to help offload some of our cases and try and get on top of our reporting backlog. But we can see from the very first data point that we are making some improvement along that way, but obviously we've got to monitor at a regular basis to make sure that we're following that trajectory, and we are held to account both internally and externally by NHS England for doing that. So that's my very brief sort of overview of the document that we've written. But I'm very happy to take any questions that people would have about details. I would just point out that, as Councillor Jones has pointed out, that on page 18 that we've left a hanging sentence where I think it says whereby, and then stops. I thought maybe it was a bit too much detail to know about how we distribute cases in the lab, but I'm happy to talk to that if people would like to know about that.
Colleagues have anything to add to that? No? No. Can I just say, councillors, I'll come to you for questions. If those of you that might not have a question, on page 13, there is a suggested approach if you want to have a quick scan. Okay. So the first person I'll take is Councillor Neil, then Jeanette, then Lucy S, and then Leslie. Thanks. And then Jill. Okay, we'll start with Paul.
Well, first of all, thank you very much for a very comprehensive report, and being a person who's got a 16-week wait for a biopsy report to come in, I'm hoping any day. So it's reassuring how you're triaging those. This is sort of going off-piste a little bit, but at County, we are moving into AI to assist us with adult care and social services, with the anticipation that we can predict and prevent much earlier on than cure when they get to my age. So is that going to be, that sort of thing, going to add to your problems of the amount of pathology tests that you're going to have? Because if we're looking for prevention, then doctors are going to be prescribing more tests and more tests. So has it been factored into your modelling at the minute, or is that just something to keep in mind for the future?
Yeah, I'm very much hoping it has the opposite effect. My personal knowledge of that is mainly in the diagnostic imaging realm, because AI is got a role in that, both the one you might think of in terms of image analysis, but actually much more in the way that your back office functions and the way you prioritize and manage workload. But I'm going to hand over to Stephanie to talk about the experience that you've had in the lab and what the plans might be for the future regarding the, AI applications within cellular pathology.
Morning, I'm Stephanie Walker-Ward. I'm the Cell Path Service Operations Manager at NNUH. I think your question was more about how the AI screening pre-everything else will change our pathology workload. Is that correct?
I'm thinking more about this is going to be the future. And,
Oh, what AI are we looking at?
What you're trying to, solve at the minute is the delays.
Yes.
But, people like us are going to be, or at this count, the adult social services are going to be piling more workload into the system. So
I think it probably depends on what the AI is directed at and at what stage. So if it's at a stage where they would then take biopsies to check earlier, then potentially, but without knowing more detail about what the AI program is directed at and at what stage, it'd be difficult to respond properly. But with proper communication around what strategies are being implemented, then we can make our own adjustments potentially together.
Paul, could you turn your microphone off? Jeanette, please.
Thank you. People across the team must be feeling under enormous pressure. I can imagine that that's not a very nice situation to be working in. It's obviously important that you ensure that you keep existing staff who are working very hard. And I just wondered what wellbeing resources you're planning to put into place to prevent burnout, sickness absence, and possible attrition.
So so there's two bits to the backlog that we've had which underlie that curve. So the first bit is the backlog in processing specimens and producing that, so the lab side, which the team did a tremendous job in actually getting that completely under control in the first part of the year. So that was a major achievement, and I think that I had to congratulate the lab staff for doing that against the background. And then what we're dealing with now is the next phase, which has proved more sticky, perhaps because the number of people involved in terms of the numbers of senior biomedical scientists and consultant histopathologists is smaller. You're talking 25 people, and therefore it's a smaller pool who are dealing with that particular issue. Again, I'm going to ask Stephanie to talk about well-being, because you know quite a lot about that.
We are a really staff-focused organisation as a whole. For this department in particular, clearing that lab backlog was a massive morale boost. They did really pull together as a team. They were feeling the pressure, but I think there's such a good team atmosphere there that I have observed both directly and via feedback. So as service manager, I have one-to-ones with every single staff member in the entire business unit once a year to give them the opportunity to tell me what works, what doesn't work, where I can help. All of histopathology have said that the reason they come to work is obviously for the patients, but also because of their teammates and the support they receive from their colleagues. So I think mutually they are supporting each other a lot. What I do for them is to make sure that they have access to the wellbeing resources that the Trust provides. So they've got 24 hours counselling helpline that they can call whenever they want. I have scheduled wellbeing practitioners to come to the department for in-person visits. So they sit with us for Wednesday every month, and people can go and speak to them. And obviously they're not expected to make that time up when they come back, because it's to make sure that they're fine. And to access the rest of the wellbeing resources as appropriately directed by Workplace Health and Wellbeing if they need the referral or whatever is available on the Trust websites. But we do really take care of people there and try and be preventative rather than reactive. There's been a lot of internal promotion as well. So with the recent take on of Queen Elizabeth's work, there was a lot more posts that we had available. And due to the national recruitment shortages, a lot of our internal staff were promoted into those roles, which has also been really helpful for them. And an influx of new staff, while it creates a training burden, also brings in a lot of new blood and fresh perspective and new energy.
Yeah, no, quite my bit, because I sort of line manager like the medical side of things, and that's where it's now moved. So that's where the sharp end is. And I can, from my experiences in my clinical practice, when we're in a similar situation in, well, not slightly different, but a sort of similar situation in radiology a few years back, recruitment and outsourcing have been the two biggest things. So in terms of the pressure that my colleagues are feeling at the moment to try and get through things, the ability to know that we have can offload some cases, particularly peak holiday times, etc., should help improve that, because it then doesn't all come down to them. They can see that there are other routes. And also, another key thing is that, like, once you can show that you're actually turning a corner, it starts to get better. So if we've got data that we can present back to show to people that actually, you know, what you're doing is making a difference, then I think really those kind of things, because people are pretty goal-driven, you know, if they see that that's what's happening, then it improves their morale and it improves their motivation, hopefully. So I think that's really important to feed back to staff, that actually the things you're doing, the efforts you're putting in, are actually starting to move the needle in terms of making things better. So that would be my take.
Would you have any resources to provide rewards of any kind? You know, an extra day off? Or...
I don't know, can I? Well, there's a few things. So people can be financially rewarded if they do extra work. So in a very, that sounds a bit crude, but it's true. So if people work above their contracted hours, and we have a system of waiting list initiative stuff that we do for our consultant and reporting staff. If they want to work at the weekend, you've got to be careful about that, because you can't use that to drive things, and we have an allocation system that tries to be proportionate and so forth. And usually people are actually pretty sensible about that. But that's one way that you can reward people with something. I think, again, from my personal experience of being a consultant, actually, what people want is a really well-functioning work environment, and actually actually being on top of your job, and is a really, going back to my previous point, really is a really positive, motivating thing. I think looking at the future, and more, this is beyond even the recovery phase from this. One thing that I think would be they would really appreciate, or from a professional point of view, would be a big future plan about where we're going with the service, and that's in terms of new build, laboratory space. You know, it's those kind of things that actually make you think, oh, that's a good place to work. So I'm a radiologist, so the Community Diagnostic Centre has been a really big thing for us. And we want to see what we can do in the future to try and consolidate and improve people's working environment. Because that more than walking around the department giving people a box of heroes or something, I mean, though that's nice, actually people will be much better knowing that I've got a place to report, good trainees, those kind of things, good IT systems, all that kind of stuff really, really makes your working day a lot better.
Thank you.
Thank you. Could I ask two things? Could I ask colleagues when they've finished that they turn their microphones off? And could you just ask one question, because I've got a lot of people here who have questions. Thanks. I'd like to go to Lucy Shires next, please.
Thank you, Chair. Good morning, everybody. I'm a little bit croaky this morning, so I'll apologise if I need to break for coffee. So I think part of this is about celebrating the number of people who are coming forward when they do suspect that they have particularly, I don't want to say that they have particularly cancer, that's a really crude way of saying it. I'm going to use an example. I've got a friend who's a sunbed user, and she noticed a mole on her back. And with that, she went and had it checked out, which is the right thing to do. And has then since had treatment. And there are a number of people within the community that I serve who have noticed things, and rather than being a little bit unsure, we've had a real push on information. And I think that has made people feel a little bit more confident to step forward and say, do you know what, I think there's something that needs to be checked out. So I think there's a little bit of celebration in the fact that as a community in Norfolk, there's more focus on maybe preventative and getting there early. And I'm hopeful that that's the reason that we've got an increase in patients coming forward for screening. I think that's really important. I think that's a huge testament really to where we were potentially, particularly with some diagnoses. So the question I've got really is looking at the data on page 16. We've got two sets of data, the number of patient cases coming through, the number of referrals, and then we've got the number of slides per patient. And I think it works out on average just below 7 slides if you average it across overall, which is obviously, if you multiply that by the extra 10,000 cases that we're seeing in 24-25, that's a lot more slides to screen. So I would like to know a little bit more about that as an average and whether or not it's the patients who are needing more slides, and if 6 is normal or if there are larger cases that come forward and where the delay potentially is with that, because we need to understand the complexity of cases, I think, leading to this. And then the additional question that I think we need to just drill down a little bit on is where we look at the average wait time, we're getting a benchmark. We're not looking at what the fastest turnaround time is and what the longest turnaround time is. So it would be interesting to know how long people are really having to wait, because the psychological impact on that is quite dramatic.
First question you had was about the slides, number of slides. There are a couple of reasons for it. So yes, the average slides per patient wouldn't affect, if there are more people coming through, the average number of slides wouldn't increase because of that. What is driving that increase is the increased complexity of the cases that we're seeing. So for extra work to be done on a case, you need to generate more slides. So that would be, without getting too technical, immunohistochemistry and special stains, things like this. And also the availability of those extra tests. So science is always evolving, and we have a lot of availability for extra tests that come in and we adopt and we verify and we adapt for our patients. So if those tests are available, then our pathologist will request them, because often they will inform next steps like treatment, what chemotherapy is appropriate, and a more directed approach to patient management. So that's why the slide numbers are increasing. Does that answer your question? Yeah? Okay, so the second part of your question. We have, it's not included in this, but in our oversight packs, usually for NHS England, we'll provide monthly breakdowns of data. So the number of cases in, number of cases out, the average turnaround time in days, and as well as that percentage completed in 10 days. And we break that down by body site. So the answer to your question very much depends on your body site. So, for example, for gynecology, your average turnaround time is 11 and a bit days. So it's not too much over the 10-day turnaround. So even though your 10-day percentage doesn't show the amount of cases coming through, like 53% at the last count, the rest of them were only waiting an extra day. So we have started to look at the SPC charts in terms of what proportion are waiting 0 to 10, 11 to 13, etc., etc. I don't have that with me, but it is something that we look at. I thought that would be too much of a technical breakdown.
If we can have a breakdown of that, I'd really appreciate that.
Yeah, but going back to the way I started off, the 65% of our backlog are skin cases. So that is disproportionately represented. And that is both good and bad, because the good bit is that often that biopsy is a biopsy and treatment. So it's not, there's not another step after that. So that is, but it is still, for that particular patient group, it's a concern. So, but we are seeing that's coming down, and we're also seeing it flattening, and they're becoming more equal across the different sites, which is both more equitable and actually shows that you're making progress.
Is it possible for you to provide the breakdown in writing to the group, and then we can pass it out to the members?
Yeah, of course. Happy to send that over.
Can I just check? I'm aware my focus was in the middle. Do colleagues on the right who... so, yes, thank you. Thanks very much. The next person is Jill, please.
Thank you. My question is about outsourcing. Certainly, at the point you were at, it was really important to outsource, you know, where you can. But I know there are potential drawbacks to outsourcing histopathology, the reporting, and how the quality and continuity of care can be maintained. Do you see this as a short-term fix to get where you were with the backlog, to get back on track, or do you think that outsourcing will be something of the way forward? I mean, for me, it would be great if there was a full set of staff to do the whole job, but I'd be interested in your opinion. Thank you.
Well, I think that's going to be up for discussion, because I think we need it now, as you said, and then we'll have an experience that we can audit and see what was that like. Because some of my colleagues' concerns is that it creates downstream work. So somebody else reports it, and then a colleague from within the hospital says, actually, I just want you to, could you just go and check that for me? And then you've got to go back and do it. So then you end up with something else good. You don't get the benefit that you might have hoped to have got. So we need to look at our experience. If you look at that graph, I don't want it to happen again. You know, so from my point of view, having oversight, I do not want to be in meeting colleagues every other day or in weekly meetings with the group chief delivery officer about what's going on, nor indeed sitting in this room again. So I'm very keen that we have a more robust system, and that may be outsourcing is part of that. I would prefer it if we had hire staff within the department to do that and expanded our consultant workload, but that is quite expensive, and you've got to think about what offers the best value for money. But that's a decision we've got to have some experience and then make a decision. But Stephanie's got more on the job experience of what it actually means in the lab, but so we may have some different views, but I don't know.
Outsourcing is something that we have done in the past. It does have its drawbacks and it does have its benefits. So the drawbacks are because it creates a lot of work for the lab. It does help the pathologists out, and that is where the problem is at the moment. So that's why we're standing that up at the moment. Outsourcing our entire lab backlog at the time when we had that wouldn't have really been beneficial, because it would have probably created about the same amount of work, bringing all that work back into the system. We need to balance the impact on patients versus the impact on statistics. So our primary focus is always the patients, and there's obviously the performance aspect around it. If we outsource cases, you need to consider who's up for MDT discussion, when that needs to come back, what sort of cases you outsource that would be the most beneficial, doesn't create a backlog in the lab of extra work, etc., etc. We have a very robust process for identifying cases for outsourcing. And when you select your outsourcing provider, we did it via a full open procurement process, and there was a lot of quality check involved in that, so external quality assurance, report checking, all of this, and they have to have their own accreditations like we do. So quality-wise, I don't have a lot of concerns, but for some cases, for example, if you have to take cases to MDT, it will probably result in your pathologist looking at them anyway, because they're not going to report a case at MDT they haven't looked at themselves. So we are looking at how to do that most effectively. For me, it isn't a reliable source of extra work capacity. It's not where I want to be, standing up extra outsourcing capacity. And it's not because they're not, the quality isn't good enough, it's just because that's not where we should be as a sustainable service, and that's not the best use of people's taxpayers' money. Every year we do a cycle of business planning in the hospital. We do really robust capacity and demand modelling. And where we see that falls over is that histopathology is such a multi-step process. It's not about how many cases you get in a year, it's about when they show up in the lab. So when we do catch-up clinics, our new head of cancer has really helped in always making sure that if services are bidding for extra funding for catch-up clinics, that some comes to histopathology. So my vision for the future of outsourcing would be that it is stood up as extra capacity to cope with the higher influx from those clinics, rather than a sustainable, I'm relying on this because I don't have the capacity, because we should have modelled that out correctly.
Thank you. That's a very common sense approach. I appreciate that.
Peter, please.
Thank you, Madam Chairman. I think Leslie and Banbridge will correct me if I'm wrong, but it came up at one of the QEH Governor Board meetings last month that from a cancer nurse who's so frustrated that the bloods have to go from QEH to NNN when they really should be going, that she can't understand why they can't go direct to Addenbrooke's, where they will end up in the third stage. So that would cut down on some of the pressures in the labs, I would have thought, at NNN. For those blood tests from King's Lynn with cancer patients, blood's going direct to Addenbrooke's, where they'll end up being with the specialist. And the other point I'd like to make is, obviously you're very aware of QEH is a RAC hospital, and the staff there have been working in poor conditions for many years without complaint. And I know that because I've been a governor there for 12 years. And they do have a staff awards, which helps morale, and also they have a weekly staff member of the week that will help with morale. Just a point on one of the questions we had here. So my question is, can you work with QEH to see if it's possible for those blood tests, concerns from that nurse, cancer nurse at King's Lynn, that they go to Addenbrooke's direct to the specialist where the patient will end up for treatment? Thank you.
So most of the things that we're talking about are not blood tests per se, but there is a pathway that does follow it exactly as you describe, and that tends to be the haematology patients who then go to the regional haematology oncology service, which is Addenbrooke's based, and it's exactly the loop that you describe there. The reason for that, again, I'll ask Stephanie to describe, but that's partly to do with the way that the samples are processed and prepared for them, I would assume.
So there are a couple of, so the blood tests going to HODS, the Haematological Oncology Diagnostic Service at Cambridge, but we also refer cases, blocks and slides directly to HODS as well if we spot something on the slides that needs referral for that service. We don't often refer bloods from histopathology, so I'm not sure what pathway that is following, probably into central blood sciences. But the reason why we don't refer directly from QEH to Addenbrooke's is because they need to come through our information management system for our pathologist oversight. So if they're talking about a case at MDT and all we've got is a report back from Addenbrooke's that doesn't attach to any patient record that we have on our system, this makes it problematic for patient management. But if it comes to us and we book the sample in, we have that record, we have the request, the pathologist has oversight and we send that onwards. But that is just for histopathology specimens, with, biopsies, etc., rather than bloods. We don't really refer bloods onwards.
Yeah, I'm sorry about that. I thought this was the opportunity for me to raise that with yourselves at the main hospital. What issues they're having at QEH, well, the frustration from the cancer nurses. If that could be explained to those guys over there, then, or bring it together somehow, explain what's going on and speak to them, see what's happening anyway and what they feel needs to be done or how they work with you.
Sorry, I'm Chris Cobb, I'm the Chief Operating Officer at the NNN. That's a really good point that you've raised. I'll pick that up with my counterpart, Richard Parker, at Queen Elizabeth, and see if there's something we can do on that. And just going back to your comments on the QH's staff awards, we have staff awards at the NNN as well, and we have monthly Pride awards as well as that. If we revert back to the question around what other incentives could be offered around that, what support is there as a package, we are about to launch into something with our staff where we've put in place a listening hub a month or so ago, recognising that the pressures that we've seen in histopathology are just more pressures on top of a year of significant pressure for lots of people. And what we've heard in there are some things we probably wouldn't have heard about normally. And what people have asked of us are things that aren't money. They're very different things. And some of those things which are quite rewarding, on the face of it, you wouldn't recognise as a reward at all, or anything that would improve morale. But there was a good example was an individual was short of 15 plastic teaspoons every day to get their job right on a ward. And nobody had been able to uplift the number from 60 to 75 for a while. It was really frustrating. Actually, fixing that was a reward in itself. So I think the listening hub and the listening tours, as we get the feedback from the staff, the response to that, I think, will be some of the reward that people are looking for. So it isn't just the QEH who have got a support package, I think.
Pallavi, please.
Thank you, Chair. Apologies for missing the start of the meeting. I just wanted to, I'm a GP and I've done lots of skin cancer work in the community. So really, I was wondering, we used to send specimens from the West to Addenbrooke's for our histopathology, and obviously that then changed quite recently. They had a huge backlog at one time for processing their skin pathology, specimens of histopathology. And then they did something which dramatically improved it. I don't know what they did. I don't know whether it was AI or something else. I just wondered if your trust was talking to them, or whether you could shed any insight into, what, and also as a broader point, whether the Norfolk and Norwich is talking to Addenbrooke's and whether the two hospitals actually sort of collaborate and work together. And actually, just going back to Peter's point, which I think is really important, we do have patients who we can't take blood samples from, and I know this is not histopathology, apologies, Chair, but it's a wider point about how we work together in the region. In the West especially, we have many patients who go to Addenbrooke's for their specialist care. And we can't take blood samples in the surgery for those patients. They've got to travel to Ely, because that's the nearest place they can get to have specimens then sent to Addenbrooke's for the lab to process them. The two labs don't talk to each other. And I think that is a big problem, but I know that's not particularly the topic today. But so it's a wider point about just the hospitals collaborating, and specifically about histopathology, perhaps if you could answer today. Thank you.
It's a tricky question to answer. We do talk a lot. Obviously, there are regional collaboration meetings. We spoke a lot prior to the handover of the QEH work. Addenbrooke's have made a lot of progress. They've had a similar level of investment previously to what we're having now, and the support that we're getting from the group and the exec teams. They did lose a lot of their work following loss of the lab accreditation, and also us taking QEH, etc. But they didn't really lose their workforce associated with that, so they've kept a lot more people with less work, so that has something to do with it, but that's not the whole reason. Obviously, they have done a lot of improvement work themselves, but histo is very much that when a backlog develops, it just shifts through the system. It's really difficult to model out properly. At best, it's heuristics, but essentially, if you have a backlog at one stage, it eventually ends up somewhere else. And the really annoying thing is that when you clear that backlog, your statistics will take a nosedive because all of your specimens are already over 10 days. So while you're making progress on that side, your statistics look rubbish. So it's once you've cleared that problem, which we very much hope to be in that position very shortly, everything should improve, and we should be seeing that sort of improvement as well. But we have isolated problems in the skin team in histo that are very different from whatever Addenbrooke's was facing challenge-wise. But we do have regional forums where we chat, and we have a good working relationship, not just with Addenbrooke's, but with Esneft, West Suffolk, Peterborough. A lot of their consultants do honorary work for us as well. So yeah, we do collaborate a lot and talk about improvements.
Just if I may come in on the wider point of collaboration with Addenbrooke's, I think what we've all learned from coming together embryonically in the group setting is that there are some very strange differences across Norfolk in terms of what happens east and west of Norwich, essentially, which some people have been aware of for a long time, and to some of us, it's quite new to say, well, crikey, how long has that been true, and why didn't we do that slightly differently? I think what the group model offers us an opportunity is to review all of those pathways and whether or not we've got the right pathways in place. I talk to Adam Brooks a lot. We've been talking to them, major developments around major trauma and what have you brought us together. Neurosciences brings us together. We do discuss lots of things. What we haven't tended to do is talk about pathways which may not be optimal within Norfolk, which have historically gone out of county, which we ought to reshape. Probably haven't done enough work on that yet, but I think the group model will allow that to be true, and I think more engagement with primary care around what that might be, I think, is essential, because I think I've sort of been peripherally aware that the QH have had patients in Lincolnshire and Cambridgeshire and places like that for a long time, but in Norwich you don't really understand the full consequence of that or what else could be done to improve the patient offer for that. But this new world of the group model, I think, is already starting to give us greater understanding of what those anomalies might look like. And as long as we have the right conversations, we can dig into that. So I'd be quite interested in getting to know a bit more about that Cambridge shift around the bloods and see if we can dig into that for you.
I have a question, but before I just want to check that members of the committee, has everybody asked the questions they want to ask? Oh, Justin, you go before me.
Hi, thank you, Chair. Thank you ever so much for coming today to talk to us. I know it's sometimes a little daunting having to answer lots of questions, but I just wanted to ask, within the paper on page 18, it talks about the clinical harm and that the impact it will have on patients, but I just wondered if there was a little bit more detail about the process of how you're capturing that clinical harm and the impact it has on patients and how you capture that data. It'd be really good to just see a bit more about the patient's experience in those delays.
Yeah, so there's a few ways. So the main way that we would collect evidence of potential harm or impact would be through incident reporting through our online system, which is currently called InPhase. And so you can run reports, and there's a little drop-down menu that says, pathology specimen related, and then you get everything that has been reported. And you can look, and then anything that comes through that process, then the team, and that includes usually Stephanie at the end of that, then has to then review that and then say the likely, in combination with clinical colleagues, what the likely harm is. And that includes, there's a compulsory bit you have to fill in that says what the psychological impact on the patient is. Usually in the view of the clinician, it has to be said. So it's not that's a failing, it's much not self-reported, the whole. So that's one way. Like any incident reporting system, it depends on people reporting an incident, and that's, we're encouraged to report incidents because that's how you find out about particular problems and identify trends. And on the whole, colleagues are not backwards in coming forwards if they do feel that something has happened which has caused a problem for them personally or for their patients. Some of the detrimental effect is covered in the paper. Is when you have a system that's not working as efficiently as it could be, then people end up having to chase things. So if everything's working well, and you don't even think about it, your results there, great. But as soon as you say, oh, actually, I've got to go, where's the secretary? He's got to go and chase that, and then we've got to get that, and then somebody in the lab's got to find it, put that so all that kind of extra churn on top of the work you should be doing makes you less efficient, which is why recovering the position is so important, because then you can get into a more smooth way of working. So InPhase is one. The second bit is through the multidisciplinary team meetings that we have. So they're every week, usually for most cancer sites, particularly some benign disease as well, mostly. So the one that I do is the colon cancer one. That's my subspecialty area. And again, as Stephanie was saying, then you've got patients that are coming through, and a particular thing in the histopathology is going to drive a treatment decision that needs to be made. So, for example, you need a particular immunohistochemistry result back so you can determine what chemotherapy is appropriate. Then that's the forum that is highlighted in. It also means that people can keep a vague eye on what's going on in terms of the general pattern of things being processed. And then there are the regular conversations that you have, the patient tracking list and other, business as usual stuff, which I don't know if you think is relevant to talk about. Yeah.
I have weekly patient tracking list meetings with all three sites, so NNUH, QH and JPUH, We also have a working shared team sheet where they're always adding patients and highlighting particular ones they're concerned about, and I'll always check that and sort those cases out for escalation. The secretaries who are preparing the MDTs will work off of the MDT lists, because also those are the crucial patients that need those discussions, so those automatically get escalated. There are a number of other targets that the other modalities in the hospital work against, which they will escalate independently, like 65-week waits, where the delay has been potentially elsewhere in the pathway, but they're still escalating to us, which we also action. I think generally having a really good working relationship with the cancer teams at all 3 sites, as well as most of the modality and divisional leads across all 3 sites. My email's always open. People know that if they give me something to do, I will do it. But there are also a lot of other people in the system that are receiving those escalations. So we're covering everything that is raised to us, we act on. So hopefully we are taking care of the patients people are most concerned about.
But we're very much in a mitigation mindset, and that is, as I say, it's not the best way to run a system, you know, but that's where we are in order to keep it as safe as we possibly can through a difficult period, and that just going to require extra manual effort to keep the ship going. And hopefully, if we do what we said we're going to do, then we'll be getting a more stable situation.
Thank you. That was really robust. Thank you.
If you'll excuse me, Leslie, before I come to you, my question is sort of pretty much along the same lines as Justin's in terms of no significant harm has been identified. I've recently had personal experience with a family member who has been treated and has been treated in the most excellent way. I don't think the treatment could have been any better. However, when you're accompanying somebody, I do notice that there are people who are so anxious and are so grateful to get treatment. And I know that there are people who are terrified of offering any criticism, because that's the nature of people who have little experience of hospitals, and are deeply worried and anxious. And I just wonder, with delays, and I just wonder, how do you reach the conclusion that no significant harm has been done? I'm not sure that you could do more than you do, and what you do is excellent. But just to say no significant harm, I'm not sure.
Yeah, it's you only know what you know, and you can have. I have to, one of my jobs is to encourage people to encourage staff to fill in the staff survey, because it's like you really want to know what you want to know. If you only find out what 25% of people want to say, then you're not getting the full picture. And that's even more so, as you just described, with some patient groups or people who fit when it's hard to reach, really. So you're never really assured. You can't be. So all you've got to do is have the best systems you can have and try and make things better with a plan. The other bit, I guess, is that things often come out of the woodwork later on. You've got to always expect that. And, we haven't had a patient safety incident that has come through the standard patient safety incident investigation process. So that would be a level of assurance and, hopefully improvement based on an individual case, with wider lessons learned. Also from the Learning from Outcomes group, which is another bit in the hospital that looks at, well, something happened and then what do we do about it, and then how do we try and make sure it doesn't happen again. So those things often may have a lag with them, because often if there is a problem that's identified, it's often, as maybe Stephanie was suggesting, it's often more than one thing has not worked, and we may be part of that thing that hasn't worked, but it may be other things. It's often quite complicated for people who have had outcomes which are not the ones that you would have hoped. So it's quite to capture that and then break that down into things and then try and make that into an action plan that improves things. Is like any public service. You hear it all the time, don't you? That won't happen again, and then it happens again. Because so we try our best to do that. And I'm not giving you a very good answer, but it's that is the way in which I'd take it as being some kind of systemic improvement based on difficult experiences, and that's the best way of handling that I can think of, because I don't think you'll reach everybody. You can. We've got patient surveys and so forth that are run, but again, not everybody will fill those out, and you get a somewhat distorted picture both ways sometimes. So yeah, it's a flawed system, and you just try and work through it the best you can. But the key thing is to make your performance the best it can be, because then you reduce the potential for harm fundamentally.
Thanks very much for the answer. Thanks. Leslie, please.
Thank you, Chairman. Part of the backlog management, there's a statement saying that the September performance figures were meeting the target. Is the target the same for every month? Because it looks as if there's been a dip in August, and then is it going up for October? I'm not very clear from the chart that was on page 17, I think it was. So does it change month to month, or are they set at the beginning of the year?
So I'll yet again hand over to Stephanie, but some of this comes into the idea of what happens when you start to clear a backlog, which is the bit that we were just going there, and that is probably why it starts to get a little bit better in terms of the figure you're looking at before it starts, worse before it starts to get better. But we also have a bit more data, sort of, than we have on that graph, but we're not quite far enough through the month to be able to have the definitive figure to put on the plot, but we will have that shortly.
The top line, the 70%, the line just above 70%, is what NHS England are holding us to at the moment. So that is the target that we want to reach. And as Stuart mentioned before, we were at this time last year, before all these things kicked in, we were there almost. The dotted line is the trajectory. So that is the target that I'm working towards month on month. Obviously, you can't improve from that nadir of just over 30% to 70% straight away, because by dint of clearing the backlog, you will dip your performance. But the improvement is showing there with the work that we have done. And the overall numbers of 2-week waits over 10 days are drastically reducing. The average age of cases over 2-week wait has also come down by over 10 days since August. So we've made a lot of progress. So the target changes every month in terms of that is a trajectory, but once we have reached the 70%, that should be the month-on-month target, and it shouldn't deviate from that. And we would then make a plan to go higher than that with the requisite interventions that we need to make to go over it.
And that's the sustainability bit, because that is I don't want to begin the same cycle that happened over the last 12 months. So you work really hard to get to a point, and then you can't sustain it, and then events happen, and then you know there must be something that we can do to improve the robustness and resilience of what we do in some way or other, and that's the job that we've got over the next business planning cycle and beyond to try and do that.
Thank you. Thank you. Any further questions from colleagues? No? Okay. I'm going to sum up now, so listen carefully and tell me if I've captured everything. Paul asked about AI and about testing for predictions. That's right, isn't it, Paul? Jeanette, you spoke of pressure on staff and how to retain people and systems of reward. Lucy Shires, the significance of people checking their own condition and the importance of screening, and asked about slides, how many slides there were. And we have been promised a breakdown of figures to be shared with members of the group. Jill, you asked about outsourcing. Peter questioned QEH blood tests going to Norwich rather than to Addenbrooke's in Cambridge. Pallavi spoke about Addenbrooke's improved skin results, and do you know how they did it? And yes, you do. And spoke of hospitals collaborating to improve the patient experience so people aren't having to travel to Ely and that their GPs could do blood tests for them. Justin spoke about clinical harm and some of the psychological impacts, and I think I echoed that. And Leslie spoke of targets, and do they change from month to month, or is there just one target? Have I missed anything that anybody said? Okay. Right. So, recommendations, please. Does anybody have any recommendations? I'm not sure that any came up as apart from us getting some figures sent to us. Is this something we would like to bring back to HOSC? I'm thinking you've set a target for April 2026. I'm wondering if sometime later next year, yes, when the contracts are sorted, is that something we could do? Yeah? Okay, thank you. So at this point, I'd like to thank you so much for coming today and answering our questions. I think the whole group would like to say we do appreciate the work that you do and how things are improving and how terrible things have been. Please God, they're getting better, but thank you so much for your time today. Thank you. Okay, guys, I'm going to take this opportunity for a break because I think speech and language therapy is coming up next and we will have quite a lot to talk about. I have the time at 11:54, so can we come back at 10 past, please? Is that okay? Thanks very much. Oh, thank you. Turning now to our second substantive item of today's agenda, speech and language therapy. Can I welcome representatives from the Norfolk and Waveney Integrated Care Board, Rebecca Hume and Karen Bryant. Can I ask that when you first speak that you introduce yourselves and provide us with your job titles? Thanks. We haven't received any members of the public who've requested to speak on this item. I'm now going to hand over to the Norfolk and Waveney Integrated Care Board representatives to briefly introduce the report. Thank you.
Thank you, Chair. My name is Karen Bryan. I'm the Associate Director of Commissioning for Norfolk and Waveney ICB. Thank you for the invite to attend. This is following the last discussion in July of last year. So we're here to talk and provide an update around speech and language therapy for both children and young people and for adult, and with a specific update on arrangements for the dysfluency service. The sort of different commissioning approaches are described in the introduction. So for children, it's jointly commissioned with Norfolk County Council. For adults, it's provision across the 3 acute hospitals and also via our 2 community providers, Norfolk Community Health and Care and East Coast Community Health Care. I'm going to talk to the adult section, and then I'll hand over to Rebecca to just briefly introduce the children and young people's section. So, moving to section 3, in terms of a system update, I have included sort of an updated gap analysis relating to each provider and the current waiting position and referral data for adult speech and language therapy for NCH&C and EC. It is positive to say that since the last update that most of the issues at the Queen Elizabeth Hospital have been resolved and services have been reinstated. The quality team at the ICB monitoring the situation just to sort of, get that early warning if any issues do occur or reoccur. And my team, the community commissioning team, also is working with them in terms of that sort of ensuring that sustained service delivery. In terms of the dysfluency and voice, so dysfluency, we do have a system-wide gap in our community provision. Both EC and NCH&C having trouble recruiting to the an alternative provider to provide that service to our population. We have engaged with stammer, who is a UK charity representing people who stammer, and they have reviewed and updated our service specification. So we're currently just getting through the sort of finer detail in terms of that alternative provision. We're just waiting for whether we need to do a competitive tender, but we're ready for that if we have to. So I'm hopeful that we'll be able to get that service up and running as soon as possible. In terms of voice, EC had also asked, the sort of same situation applied to the voice element of the service. But I'm actually pleased to say that since this paper was written, EC have had successful recruitment to speech and language therapy, and therefore they feel able to address the issues around the sort of voice service in-house. So I think that's good news in terms of no need to look for alternative provision, and I hope that we'll see a more sustainable service there soon. There is still a service offer there, but I think it's sort of quite ad hoc, but it should then move into more sustainable service. There was discussion at the last meeting around a system review of adult speech and language services. Unfortunately, that has been delayed in trying to find a resource to take that review forward, because it's quite complex, covering a number of providers. But again, pleased to say that we have identified a resource, and that review should be concluded before the end of this year, the calendar year. But it's not that my team, myself, have just sort of been waiting for this review to happen. It's, you know, my team have picked up specific issues like the Queen Elizabeth, the disfluency, and the voice. And there's also been something around the head and neck cancer pathway between sort of Norfolk and Norwich and NCH&C that we have also picked up. So, and I have continued to escalate the need for the system-wide review, so I am pleased that it's finally taking place. So that's my introduction, Chair. I'll hand over to Rebecca for the introduction into the children and young people's section. Thank you.
Thank you. So I'm Rebecca Hume. I'm the Director for Children, Young People and All Age Safeguarding and Mental Health. Slightly changed to what's on my badge there. So again, this is an update from our report of July 24. And I hope the information there demonstrates the continued work with our commissioning colleagues in Norfolk County Council. It's a slightly different approach to in adult services because it's much more about the developmental needs of children and young people and how we link in with them from an educational perspective. The paper will demonstrate that there is increasing demand coming from referrals and requests for support. But despite those that increase, performance has remained quite solid, and actually the longer waits have been reduced over that time. So the transformation work that the provider has undertaken, and also there has been there's been a lot of work around making sure that we're trying to right-size the workforce for the demand. So that's proved quite successful. It's an iterative piece of work because of that shift in demand all the time, and we need to think about different ways of managing that demand, because actually it can be met by lots of other parts of the system. Doesn't always the demand doesn't always need to be delivered by a speech and language therapist. They are there as the experts in the system. I'm not going to go into a lot more detail because I hope it's in the paper. So I'm very happy to answer questions from the committee. Thank you.
Thank you. I'm just going to look to the right first because I did the middle last time. So we've got Leslie and then Lucy Shires. Anybody else? Lucy G. Okay, thank you. Paul. Anyone else? Jeanette? No? Pallavi? Yep. Okay. Could I ask people initially just to ask one question and then we'll see about going round for a second round. Thanks very much. I'd like to start with Leslie, please.
Thank you, Chairman. How many speech therapists does the service employ?
Which, in the totality, for adult or for children and young people?
Both, I suppose, really, because I'm just wondering if you have enough people. And you probably will say, no, we don't, but I think it should be aired and recorded that you don't, if that's the case.
Yep, no, thank you. It's sort of coincidentally, we're just in the middle of planning round at the moment for 26-27, and that's where we sort of triangulate our workforce, demand and sort of financial data. And I know that actually speech and language therapy has been highlighted as a specific hotspot in terms of vacancies. So I think from that we don't have enough. I can't give you exact numbers, but we could take that away. I could take that away as an action. But I think it is now through this planning process that we need to, and also the review in terms of the adult, we need to triangulate all that information to be able to sort of address what we can do. And I suppose coming back to Rebecca's point in terms of it might not necessarily be a speech and language therapist that is required, but I think as part of the review in adults, it is about sort of, that will be part of that baselining in terms of that data and then working with our workforce colleagues as well. I don't know if you want to add anything, Rebecca.
Yes, so we can provide that data, but I don't have it in front of me at the moment, so I can't give you the numbers. I'm happy to supply that afterwards. We have just undertaken quite a solid review with the provider around their workforce because there have been particular challenges around capacity, and we did give some short-term funding which increased their capacity, and there was a risk of losing that. So we maintained that funding between ourselves and Norfolk Children's Services so that they could maintain their current workforce. Demand is increasing. We do need to consider skill mix. So do I think that we could do with more speech and language therapists? Yes, but I think we could do them with them in lots of different settings as well. So thinking about our youth justice service, thinking about how they link in with our looked after children provision. There's lots of areas where speech and language therapy can be a really good addition. There's not a huge number of speech and language therapists around, so we have to deploy those that have that qualification to the best possible setting. But I can happily get you the number for this service. We can do that. And of course, there were speech and language therapists in the acute hospitals in those settings as well, because of the need to acutely address things like stroke, swallowing difficulties, things like that.
If I could just add my own comments, and that's that you've highlighted the areas, and I think that the public isn't always aware of the work that is done. So thank you very much.
Sorry, I would like to just come back on that. And I think for many therapy services, when people think of health service careers, they're not always thinking about some of the therapy areas. And so there's a lot of work nationally around trying to enhance access to those careers, because we have so many. You've had histopathology here this morning. You've got many different, audiologists. You've got so many different specialist groups, and we do need to do a lot of work at trying to enhance entrance into those careers, and not always just focus on doctors and nurses, because that's what people think those are the people that deliver healthcare.
I'll invite somebody to come and talk to pupils at the school, of which I'm a governor.
Thank you, Leslie. Lucy Shires, please.
Thank you, Chair. I just want to take a moment to just pay tribute to all the parents, TAs, volunteers, anybody in schools that are currently delivering speech and language therapy to young people. I've spoken to a lot of parents who are doing it and absolutely terrified they're not doing it properly or they're not doing a good enough job. And I think that level of responsibility, as we've just said, it is a career. And when we're putting that professional career responsibility of delivery on parents, I think we're causing far more stress and anxiety than perhaps we should be. And maybe we need to look about how we get that into our communities in an early years level. So it's just a blanket thing such as phonics, because the phonics scheme really, really has uplifted children's reading. So with that in mind, so that we can just drill down into some of the data that we don't have. So it looks like just under 4% of Norfolk's children per year are referred for speech and language therapy, but we don't have any breakdown of what age groups they are. And with the same vein, we don't know how many children are currently supported by speech and language therapy or what age groups they are. So could I please have some data? Because I don't think we can have an informed discussion because we don't seem to have enough data on it.
Yeah, we can certainly supply that data. Can I just respond to your comment about the input from parents, TAs and education and what more broadly sort of early years settings? So there is definitely a need for support for communication needs. Not every child that has a speech and language communication need requires a therapist. There are some that are very complex that have underlying, children that might have cleft lip and palate, or children with Down syndrome that really do need that consistent input from a therapist. But the balanced model, which is a nationally recognised model, recognise that the value of repetition, of kind of reinforcement of techniques for speech, language and communication. And actually a lot of us do that every day with our children, our grandchildren and children that we come in contact with. But that's a skill, and that's where we need the therapy or the therapist support to come in and teach others that skill. Now we're trying to work, that's why we jointly commission with Children's Services. Obviously we've got the Family Hubs and Start for Life programme. There's a lot of people working in that early years space that need to develop those skills about developing communication. And also we need to be picking up very early where there is a communication need, so that we don't wait for a child to get to school so where they will struggle with language acquisition, learning to read, because they haven't actually they're not school ready. So I think that this is the next stage of work that we need to do, to be working with our wider system to encourage that kind of that repetition of work that's needed on a day-to-day basis to develop those communication skills in our children and young people. So certainly in that early years space, I think there is a real role for others working with children, childminders, all of that, to pick up, actually this child's not communicating as we might expect at this stage of their development. What extra support can we put in? What resources can we direct them to? And that won't always be a speech and language therapist. Okay. And the other data, we can get that for you.
Thank you. Lucy, please. One question.
I wanted to ask on page 24, 2.2, it says the current contract is due to end in August 26. So when does the procurement process start? Because I'm aware in the document there's mention of a task and finish group that's a potential recommendation, and there was a survey in May that we haven't got the information from in here, and those could be quite useful in informing the procurement process. So just formulating probably that into a question is, when does the procurement process start for the current contract, and what information will be useful for that we can help with here?
So that process has already commenced, and we've already been in early conversations about the most appropriate route to do that, and it has to fit in with obviously all the procurement processes that both parties have to go through. So the lead commissioner is Norfolk County Council, and that's already started. We're in discussion with the current provider and trying to find the most suitable route for that procurement. Obviously, we have to be quite careful when we're in that space to discuss more widely, but we're acutely aware of the need to make sure that there's continuous provision for those young people. Part of the work that we do through the Strategic Alliance includes this type of needs, considering speech and language therapy, and we do also do a lot of work with parents through the SEND surveys, etc., which will also raise to us where there are needs around speech and language therapy, and to take that feedback directly from parents and families. So again, we're taking that information about how we develop our services. We look to best practice. We work with other providers to see where their performance might be better. It's a bit of a challenge everywhere, but we are trying to learn from best practice. We're trying to review our pathways to make the best use of that specialist resource and see how we can train others, such as assistant practitioners, to deliver some of the programme. And we are working to see how that moves with our education in early years settings. So that is all kind of being considered. And I did mention we've just the paper mentions that we've just done an open book process with the current provider as well, so that we have got that detail about what the workforce needs to look like and what the modelling for future demand might look like too, so that we can have sort of more flexibility built into our planning.
Are you only talking to the current provider in the procurement process then, or are you at this present stage, and what could HOSC do in terms of feeding in information into the review pre-procurement?
So we are making procurement decisions as to what the process will be for that procurement, which might be an extension of the current contract if you're looking at the most suitable provider, or we may actually be going out for procurement. But at this stage, that isn't known, so that's why we can't get into detailed conversations with any provider at the moment. We need to if we go through that full procurement process, the same conversations have to be available to whoever might be interested. So that's why I sound like I'm being cagey. I'm not. I'm trying to make sure that we're following the correct processes.
Thank you. You will have an opportunity for more questions afterwards, Lucy. Paul, please.
Thank you, Chair. Before I ask the question, I don't know whether I'm the only one, but the PDF that I've got in front of me, it's very difficult to actually read those bar charts. But there are words to go with it. So I note that you've given us a rundown of when referrals are actually seen, but then what happens after the assessment? Because then they must need, or if they're assessed that they would need support and provision, do they go back onto another waiting list to get that? And if there is, what is the waiting list for them to actually receive the support and provision they need?
So the answer is they don't go back onto another waiting list. Once the assessment's complete, a plan for that child will be developed with usually with education and with the family. And depending on what the need is, because as I explained, there's a wide range of need, that will either be built into an education, health and care plan, or it may be just separate to their education, health and care plan, that they have a treatment or they have a plan built for what will be delivered in terms of being able to support the need that's identified. So there isn't a separate wait for that. These are the wait times, and there are a lot of children who are currently in service, which is the question I think that Lucy asked earlier. This only tells us the numbers that are waiting for things. It's just so how many are actually receiving support from a speech and language therapist, and we can come back with that data.
Thank you. Pallavi, please.
Thank you, Chair. Thank you for your presentation. I have a few questions, actually, but I'll try and keep to one. I'm a little bit confused. So we have Cambridge Community Services, which provides a contract for children's services, which is due to come to an end, and you're procuring a new one. And then there's East Coast and Norfolk Community, which provide adult services. So the latter two are going to continue, is that right? They're not coming up for review.
They are continuing, but they do have a contract end date. Where are we? March 27 potentially, but we're not. The service will continue, but we're still, I suppose, similar to Rebecca, just having conversations around what we might do next in terms of community provision in the wider kind of, not just around adult speech and language therapy. And then the 3 acutes also provide adult speech and language therapy. There's no contract end date as such for them. That's a service that sort of just goes on and on.
So in terms of the adult services, there's obviously quite a wide variation in waits between the two providers, and I'm sure you're looking at that. But also it occurred to me that 18 weeks is a long time to wait if you can't swallow, which is what a lot of the adult referrals are about. Or if you can't, whether it's because you've got a tracheostomy, you've had a stroke, or, so there's something else going on. I don't know where the 18-week benchmark came from, but it feels inadequate, and it'd be good to know, to be reassured that actually people are waiting a lot less than 18 weeks to be seen, even within Norfolk, within the NCH&C area.
Yeah, absolutely. So that does cover all patients waiting for speech and language therapy, and sort of on reflection, probably if we could get that broken down into conditions, that would probably give you the reassurance that you're looking for. I know that with the gaps that we've had in terms of sort of disfluency and the voice, with the sort of vacancies in speech and language, they have had to prioritise the urgent, kind of more life-limiting. So the examples you gave in terms of the swallowing and the sort of post-stroke, so they are absolutely prioritising those urgent kind of clinical conditions. But I want them to be able to provide a service to everyone that has a speech and language therapy need. Hence, me keep continuing to push for this review, pleased that it's happening. And then I hope at the end of it will be a kind of I think, reflecting what Rebecca said, kind of, it is kind of spread all across these different providers. How can we do better together? We do have some issues in terms of the sort of interface between the providers as well. So it's kind of what can we do better together with what we've got, but then, like Rebecca said, best practice, benchmarking, kind of where is our ambition? So I'm hoping after this review, particularly around the adults, that it will be a much more joined up model of care. But I will take an action around to give some assurance around the patients that are waiting this long. But I agree, even 18 weeks is too long, isn't it, as well? So we will be monitoring this at our kind of monthly contract meetings with NCH&C and EC as well. Thank you.
Thank you. I'd like to ask a question, please. I was somewhat shocked to see that no pathway is available for prisoners. No pathway is available for prisoners. Now, we've got an elderly lifer unit, haven't we? I think it's still called that at Norwich Prison. So you've got people there. I guess you've got all sorts of physical difficulties, maybe having had CVAs, maybe having dementia. I know that there are a lot of very disadvantaged people in prisons who do have huge communication problems. So how can it be that no pathway is available for prisoners? Is that wrong?
I believe it's around the East Coast in terms of their provision. If there is a need, then that will be addressed, but it's about the formal commissioned pathway. I do know that there are conversations between the different providers about the in-reach and outreach. I know I had a conversation with NCH&C about it recently. Also, prisoner healthcare is commissioned nationally as well, but it's certainly, I think I just need to find out more. I think there definitely is access to services, but whether it's about the formal commissioned pathway, but I'll take that away, and that's definitely part of the review as well. There's, around, I think in terms of your prompt notes, the prisoner, the people with dementia, I want to make sure that this is, for those that need it, that there is a kind of clear service offer.
But right now there isn't one.
I think in the East, if that's what, in East Coast, so the Great Yarmouth and Waveney, no formal commissioned pathway. Do you want to come in, Rebecca?
How about the rest of Norfolk?
Yes.
Could I just ask Health Watch to make a note about this and, maybe speak with me afterwards about this? Thank you. Okay, second round of questions, please. I've got some first round people now. So I will have Justin, Leslie and Peter. Yes, thank you. Justin first, please.
Thank you, Chair. Just firstly echoing Councillor Shire's question about a little bit more data around the number of referrals in and where they come from, etc. Would be really helpful. My question is around mental health services. I can see that NSFT, this conversation is taking place around provision, because I think at the moment there's liaison with MDT work that takes place, but I do know that, for disclosure, I work for NSFT, but I have had conversations with quite a few people around the dementia services and the adult provision, and I know that it's desperately needed. How far have you got with conversations with NSFT around the implementation and support? And is there anything we can do from HOS to support that process as well?
Thank you for your offer. I may come back to you and then take you up on that. I know it's provider to provider discussion at the moment, but we will kind of learn from where it's got to and address through this review. So I can't add much to that now, but I can come, I may come back to you for some assistance on that one. But I know that, I think I referenced before, the sort of interface between, or the referral pathways between providers could be improved. So that's definitely something that I want to get clarified through this review.
Thank you.
Peter, please.
Thank you, Madam Chairman. I was just going to ask, will there be any speech therapists on the staff at the new SEND school, which is going to be opening soon in Swaffham? Because I do know of a resident of mine I'm trying to work with at the moment who's got a non-verbal autistic child, and she's struggling actually to get a place at that school. So, and I think that's the future, and that's the only place this young child should be going, really.
So the provision is universal across schools, and those, I think the former question that came through about data around where is the need, there is data around actually what type of need is in different settings, where are the referrals coming from, we can kind of report on that. The reason we jointly commission this is for that very reason, to make sure that we're very aware of where there's new school resource spaces coming online, what the cohort of children that will be allocated to those schools and what their needs are. So we work really closely with the provider to make sure that they are aware of the new schools as they're coming online. And that's a lot of the work that we're doing around school and community zones, which again, the children's system is very connected around that work, so that we have multi-agency and multidisciplinary approaches to meeting the needs of children. Of course, there is more always that we would love to be able to do in terms of resource, but what we're trying to do is use our resource that we do have in the best possible way, so that it's not sitting in silos, that we can all access, and we're working as multi-agencies, multidisciplinary. Because that will help us to identify need earlier and meet it need earlier, and share resource to do that. So yes, we are aware of the new school openings, and so will the speech and language therapy provision.
Yeah, because I was thinking that the school there, I do know that children right across the county, even right on the Cambridgeshire border, will be travelling to that school, which is saves them coming to Norwich or Lowestoft, where they've been travelling apparently. So I would assume that would help to congregate your staff in that one area, rather than having them scattered all around different schools and facilities across the county.
So the way it works is there's not a specific person. One person won't be attached to the school, but they will be a team that works around school, a school and community zone. So they will be part of a network approach, and they do in-reach and outreach type work. So there won't be one therapist that will be attached to the school. And actually, if you do that, you have a single point of failure, because if that individual therapist is not available. But it is also about supporting the school's approach to because obviously, even if you had a therapist, they can only be with one child at any given time. Whereas a teacher is with that child in class most of the day. What can they do to support the needs of that child? And the family obviously have that child at home, and the therapist can't be with them all the time. So we need to be able to support them, and that's what the balanced model is: trying to upskill people, make sure there's resources available. I accept what Councillor Shires said, that families can feel anxious, and we need to make sure we're addressing that they feel that they can access support when they need it. There's lots and lots of resources available that we try and direct them to, but it has to be very personalised, because not everybody's need is identical.
I must commend County Council on building that school, because I think it's very much needed, and it will save that, like you said, bringing all the agencies together rather than scattered around the county. Thank you.
Jeanette, did you have a question?
If possible, Chair, it's not really a question, but a kind of comment. Thinking to the future, I think I'd like to kind of reinforce what Leslie said. There needs to be much more awareness of the therapies. I talked my granddaughter out of medicine and into occupational therapy, but I have to say, she's a really bright girl, but she had no idea that all these therapies existed, including speech and language therapy. And I honestly think the key is in schools, because all schools, all of our high schools, have career activities and career days, and I think you need to get in there, to be honest, to raise that awareness. Because once kids realise what a wonderful job it is, they would be really keen.
We have an open offer to, Leslie mentioned earlier that did you say you're a governor in a school? So I think health services, and particularly workforce leads, I'm not a workforce lead, we will always be receptive to what we can do. Obviously, it's better if we can do it on a bigger scale, and we will always try and make it apparent what the diversity of careers are. And I'm a registered nurse by background, and my career has been so varied, and I think people think it's a single thing. we have a GP here, and I think those portfolio careers are really exciting for people now, and we've got to appeal to the younger generation. They have very different aspirations around their careers, and I think it is really good if we can get into schools. I know we can always find people to come and talk, so if anybody wants somebody in a school, we do work really closely with careers fairs. When they have those, we make sure that we field people, but certainly the more we can do to encourage people to look at the wide variety of careers that are in health and care. We mustn't forget our care colleagues, because without that support as well, health can't function. So I think the more we can do to encourage people into health and care careers, the better, because they are varied. If you've got somebody bright, there's a lot of different routes that you can take once you've got your professional qualification.
Before we move on to round two, can I just have a clarification? Isn't there a statutory timescale for children and young people to be seen? Is it legally binding?
So are we talking? There's a lot of different routes and requirements for speech and language therapy. So if you're talking about through the Education, Health and Care Plan route, yes, there is, and we do. The data's there. We can provide data about how responsive the service is to meeting those timescales, and I think the information's there. I agree, it's not easy to read, but we can provide more data around that. The performance is not getting it. It's improved and it's not getting worse, and the longer waits are getting shorter. So whilst we don't always achieve the timescale, those that are not achieving it, that proportion is getting smaller.
The people I have wanting to ask a second question, I've got Leslie, I've got Paul, I've got Lucy G, and I've got Pallavi. Does anybody else want to ask? And Lucy Shires. Anyone else? Okay, then let's start with Leslie, please.
Thank you, Chairman. I was going to ask about priority of need, but it seems that the need is so great that it must be very difficult to prioritise. But in the gaps, some of these gaps are real worry, aren't they? I mean, the Chairman's already mentioned about the prison service. For instance, the Queen Elizabeth Hospital, Peter and I both appointed as governors there. We don't have much influence, I don't think, but how will you know that it's been addressed at the QEH, the support for stroke patients? I mean, the stroke area was really, really good at one time, and it's had a bit of a dip. And how will you know about some of the others that you haven't put dates on? Because that's important. And you know, is it something that we need to break down to bring back as an item in rather than a general item? So it looks, for instance, as if one of the, or possibly both the providers aren't up to scratch on what could be done. But you're looking at that at the moment, aren't you, for next year? Sorry, a bit of a vague question, but it will help explain it to all of us.
Thank you. Yeah, absolutely. I want to take this and get further clarity through the review on this, on the gaps there. And I was just reflecting on the EC and the prisoners, and I was just trying to remember whether there is a prison in that area. So maybe that's in Great Yarmouth and Waveney. So maybe that's why that's noted there, but I need to get to clarify that, so I will pick that up as an action. In terms of QEH, well, in fact, all the providers listed, we have monthly sort of contract quality meetings with them, so we'll be monitoring kind of waiting lists, numbers, issues there. Also, the quality team within the ICB, they join the Trust's actual internal quality meetings, which I think is a real positive that they've sort of been invited in and listened to that. So we have kind of eyes and ears everywhere in terms of monitoring this. I know this is one of my top priorities to try to resolve, and as I say, I'm pleased that the review is finally underway, and it's a risk on our commissioning and performance committee as well. So if that doesn't start improving in terms of reducing the risk, then I'm going to be asked questions as well. So I think there is quite a lot of scrutiny around on this. But I would maybe ask in terms of we come back with the review kind of outcome, and then hopefully that will give a better picture and solutions to some of these gaps. And I suppose kind of weighing up the risk of these gaps and the numbers as well, I think would be helpful. Otherwise, I wouldn't want to sort of set hairs running, as it were. So to have that more informed discussion. Thank you.
Can I just comment on that as well? So stroke in general is a clinical priority for the system. And so I try not to talk about the ICB when we talk about priorities, because we do have to work as a system. Chris Cobb talked about the group model, and there are definite advantages there. How can we make sure that we are best utilising our collective resource in these spaces? It's limited. We know that we're not going to get a great deal of new investment, but it's about streamlining what we have and targeting, trying to address the inequalities and prioritising our resource. Stroke is one of those priorities. There is that balance that we have to get in place around what do we do in the preventative space, so how we case finding at a sooner opportunity, what we putting into modifiable risk factors, and that comes back to how we work with our wider system. How does public health help us in this matter? How do we work with all our as the other wider socioeconomic factors that impact on people's health and well-being? So this kind of working in a system approach has to be the way that we go forward, utilising our resource and having the same priorities that we're working towards based on what our population need is. So it has to be a very localised response, understanding where the need is, and collectively saying, what can I bring to the table to support this vulnerable group?
Thank you. Paul and then Lucy Galvin, please.
Thank you, Chair. I've just got a note here. You were asking a question about EHCP's assessment times are 6 weeks legally, and I think there's about a third of the cases here that have gone over that, but that's not my question. I see that there's provision for linked therapists in primary schools. Is there any provision already or planned for early years and secondary schools?
So yes, this is where we're coming back to this, the school and community zones, and trying to align our resources around, it's not in the paper, trying to align our resources around that multi-agency, multidisciplinary response around clusters of schools. So we have link workers in primary schools. The greater need tends to be in the younger age group for speech and language therapy, but we also have provision for case finding and directing resource within all schools now because of the school and community zone work that we're doing. So the Cambridgeshire Community Services very much try and align their teams around a cluster of schools so that they can be responsive to the need regardless of what it is. We've also got our mental health support teams which are aligned to those school and community zones, and wherever possible we're trying to do that on a system basis because we recognise that actually one part of the system doesn't work without the other when you're talking about children and young people's health.
Thanks. Lucy, please.
Thank you. Sorry to be jumping around from different area to area. But I think this is related to that as well. So on page 23, just quoting from it, says the scope of support available is not the same. In line with the commissioning arrangements, local authority has a duty to support language development and associated special educational needs and disabilities, whereas in adulthood, SLT is typically focused on clinical intervention following a stroke, traumatic brain injury or degenerative neurological disorder. So I just wanted to ask a question around that and then make a potential recommendation. But that does sort of suggest a bit of a cliff edge for children with special educational needs when they get to 18. There seems to be a gap there because the Children and Families Act covers individuals up to 25, doesn't it? So there's that gap. So is there an offer to children with SEND up to age 25 within our system? And could you just clarify that and maybe correct it in there, because there is a bit of an overlap, and also explain how that works in practice, especially as the adult service is delivered by a different provider. How's that crossover done? But then my recommendation, just to pop it in here while I've got the mic on, is to have a task and finish group to look to sort of assist really in this area, perhaps to give feedback, which hasn't happened from families, SEND users, etc., to be part of that system-wide approach that you're talking about, that to bring that voice in from users, because I agree with you, you need a better needs analysis because you're busy looking to help the need all the time, and you haven't got time to do the proper analysis. But we can help, hopefully, if we can. I know there's a proposal. I think there's a proposal for a task and finish group, so just popping that in there. But the question was really, what happens between the age of 18 and 25? Is there a cliff edge, or how is that managed?
So again, it depends on the need that's been identified. This is why we jointly work with Children's Services, and they are the lead commissioner on this, because obviously with the Education, Health and Care Plan, that is up to the age of 25, and we do work with colleges and further education institutes. So there is an offer if it relates to the Education, Health and Care Plan. There's also an offer for children once they go beyond that, but they will go on to depends on the need and whether they are on the adult pathway. For that type of language acquisition, it is a different need to if it's a swallowing or a functional difficulty, and they would be able to go on the adult pathway. We have this issue all the time with transition. We try and address it. We are actively communicating all the time to try and make sure that we don't have those cliff edges. We do work with parents, so our Family Voice have been involved in kind of our whenever we set up service specifications, and very much they feed back what their families are telling them. So we meet really regularly to hear from parents what the challenges are. We obviously have the tribunal process, which ideally we wouldn't ever get to a parent need to go to tribunal, but there's learning there for us as a system, what the gaps are, how we address those. So I would always advocate for more resource for children and young people. That's my job to do that. But what we're trying to do is make the best of the resource we have, make sure we have that effective communication, that we're listening to what the issues are, and that we recognise there is always, whatever age you transition at, there's that awful moving between services, and there's lots of other transitions that children have to address as well. You know, leaving school, commencing adult life, and that's a lot for them to take on board. So we are trying wherever possible. We've got transition networks that we have, parent carers are involved in those, and we try and speak to young people as well to understand what their issues are. So absolutely take on board all that you're saying, and it's kind of my day-to-day worries are often about how we make sure they don't face that cliff edge, and how do we best utilise our resource collectively.
Sorry, Chair, could I also just add that in terms of the adult review, I have a specific ask in there that transition period is considered in there. So, yeah, that's covered there too.
Thank you. Lucy Shires, please.
I just want to touch back again on the conversation that we had earlier about how we, not so much preventative work, but how do we do that early work? And while we've been in the meeting, I've done a little bit of reading of legislation and where our responsibility is as a council. So we need to figure out where this is going to go, Chair. So I'm sorry if it's a little bit all over the place. But our responsibility, reading the government's website, is that we have to make provision to ensure the accuracy and consistency of assessments made by early years providers in the area. And that will include childminders who have to sit under the framework too. So at some point we will have everybody's attention to say, this is the information we need you to collect and this is how you're collecting it, which is fantastic because we can then side sell the speech and language therapy, which I'm assuming that we do. But the issue is that all that data's held, So you'll be able to see where children are on speech, because there's speech and there's reading as part of that. At the point that we know where children are we not doing something then? Do we really know how big the issue is? Are children waiting too long to get help because there's something that needs to be done far earlier as a massive collective, which is going to be time intensive, which is going to be really costly, but could vastly improve children's lives and prevent this 5,000 to 6,000 children coming through to us every year saying, I need help. So we need to know who we need to talk to and who we need to put pressure on to make sure that children are getting seen and supported at the earliest level. So there's probably going to be a letter to the Department for Education coming from this committee, but we need a steer on what we need to do.
Absolutely. So there has just been another joint strategic needs analysis for SEND, which has been recently published for Norfolk. So that kind of capturing what is our need, so we really understand that. This comes back to that system approach again. We do need to involve everybody who's in contact with children and young people, and I completely agree. The sooner we identify a need and address it, it has to be more beneficial for the child and their family, but also beneficial for us as a system, because actually we shouldn't wait till a need becomes such that you need a referral somewhere. We do need to be involving all those early years settings, and that's part of what the the Families First Partnership Programme, I always call it FFPP, the Families First Partnership Programme approach is encouraging us to do as a system. How do we collectively come around families in that early years space to make sure that we are working with families to identify need, and actually being able to address inequalities in that space as well. So that's very much the work we're doing. It's a challenge to do that preventative work at the same time as doing the work around, but that's why we need to work as a system. We work really closely with our local authority colleagues. I'm a joint post. My team every day will be meeting with somebody in Norfolk County Council to make sure that we're aligning our work streams. With all the other issues that we have, we need to find the time to do that. So I think the JSNA will be a really good place to start with that. But the modelling that we're doing around how do we have neighbourhood health for children, there's a new model that's coming through the health route that will help us address some of those, to do case finding, etc., and to deploy our multi-agency response to that at the earliest possible point.
So I guess there's always one big ask, right? So every department of every public service knows the one thing that they need the government to change. In this room, we can write to government and ask them to change something, and you all know what that is. We don't, because we're not on the ground. We see it in our communities. So I'm not worried whether or not we do it now, whether or not we do it when the chair's summing up, but I do feel that whilst we have people who are delivering the front line in this and the families that are supported, we can't keep putting the burden onto communities and frontline services. Something needs to change in the overall education system to make sure that children and young people aren't missing out on education because they first need support with speaking. So ideas from the floor on what we need to do. I'm not the expert in the room.
Can I just comment on that? Because I think what would be helpful from my perspective is single policy that comes down. We have a lot of policy that's issued. Some comes from the Department of for Education, some will come through health, some will come from the Department of Health and Social Care and come through the social care route. They all generally have the same aims wrapped around them, but we need at a governmental level those departments to work together to agree joint policy that is directed towards children. Because if you read a social care directive, it will say, and you should work with health and education. If you read something that comes from education, it will say you should work. But of course, I'm going to be looking at the health service policy that comes down for my must-dos. If it was a single policy, that would be incredibly helpful in that early years space. So if that would be my plea to central government, that we have joint policy for children and young people in early years. and that it doesn't come from different directions. It is genuinely the same thing that comes through the 3 routes.
Thank you for that. Thanks very much. Pallavi.
Thank you, Chair. I just want to make a point about the task force that Lucy talked about earlier. I've heard your answer, and I actually feel quite reassured. So, just my tuppence worth, my opinion. My question was, why are referral numbers increasing in young people, in children? Do we have any idea? Can you shine any light on that? Because actually, the number of children being born is decreasing. So why are referrals increasing?
It's very complex as all these things are. We don't have a single reason for that. Some of it relates back to social interactions during the COVID period. We think that lots of children were in their own homes. Some of it relates to digital access, that actually lots of people aren't having the same conversations. They're not noticing those developmental issues. Some of it's socioeconomic factors, we think. There is a big demand, and it's not all health related. It's more around communication needs. So that's why, again, coming back to that, understanding where the need is coming from and what different things might address it in the early years space is really important, I think. They're not all needs as in there's an underlying functional issue with children. A lot of it is language acquisition. And that's the bit we need to address collectively. How do we improve language acquisition and school readiness for children and young people?
Thank you. May I just... So on the back of that, what I would really like is for us to ask, if we're going to write to anybody, to ask them to look into the reasons why children's language skills are poorer in the early years. And, you know, other countries have imposed bans on children using devices and such like. I really think we need to grasp this in this country. I think we need to have some national policy guided by the best available evidence so that we protect our children and give them the best start in life. Thank you.
Thanks. Can I just ask a question? Would it have been helpful to have somebody from Norfolk County Council here? Do you think?
We did work on the paper with them for the children's element, and we, you know, I've been in 2 meetings this week where we've talked about speech and language therapy with the provider as well. But yes, I mean, we deliver it together, we manage the contract together, so always very happy to have a colleague from Children's Services with us as well.
Yeah, I think that would have been useful for colleagues here to ask questions. I don't know I don't know if that's like our fault or nobody's fault, or maybe it just wasn't even thought of. But I think for anything in the future, that would be very, very good. Thank you. Okay, right, I'm just going to go through, there's a lot to do here, so if I miss anything, please tell me. I'm going to go through the discussions now. I'm going to go through first questions and then second questions. And then I have some questions to ask you about task and finish groups and about letters. Okay, so bear with me. Okay, so the questions that were asked. Leslie initially asked how many speech and language therapists were employed, and did you think that there were enough? Lucy Shires praised parents and carers who are providing speech and language treatment therapy to their children, but emphasised there was a need for greater statistical information. And I actually think the need for greater statistical information came through a lot of people's questions. I think, you know, with respect, I think the report a little bit wholly on terms of the information. Lucy Galvin asked, when does the procurement process start? And I was also interested in knowing whether or not only the current providers would be considered. Paul asked, what happens after assessment? Do people then go on to another waiting list? Pallavi was asking about the 2 different providers, one for children, one for adults, and will they continue in the future? And also mentioned that for adults, 18 weeks is a long wait. And where did the benchmark come from? I got a bit impassioned about people in prisons. Justin spoke about asking for data about the number of referrals and NSFT and the support that NSFT have. Peter wanted to know if there were any speech therapists at the new SEND school in Swaffham. Jeanette spoke of a need for more therapists to be trained, or for schools and for this to be mentioned as a possible career pathways for people to be more aware. Round two, Leslie asked about gaps in provision. Paul asked about link therapists in primary schools and any plans for provision in senior schools and more junior schools. Lucy Galvin spoke of the cliff edge at age 18 and then between 18 and 25, and also spoke about the need for greater analysis and also for the voice of users to be heard. Lucy Shires spoke about how we do early work and how can the council achieve the goals and get the information from the data. She asked how big was the issue and what we could do to help, and asked about us sending a letter. Pallavi asked about why are referrals increasing and why generally in this country, let alone the county, why language skills seem to be decreasing. Have I got everything that everybody said? Okay, right. Moving on to my charming minder here, who will help a lot with this. We want to ask about a task and finish group. Now, I want to ask the members here, are you happy for us to have a start and finish group? If we do, then Becky here can talk us through how that will be done. And if we're going to send a letter to government, would we send that before or after the task and finish group? Or would we do one before and one after the task and finish group? And also there was something additional that should be included in the task and finish group, and that was Lucy's suggestion, Lucy Galvin's suggestion, that's right, isn't it, that we could add something to the task and finish group. And I've lost my notes.
I can speak to the task.
Yes, please do. Yeah. So before we make a decision, Becky is going to speak to the task and finish group, and then I will go through the options and we will vote on them. Is that okay with you guys? Is that clear as mud? Okay, thank you.
Thank you, Chair. So the idea behind a task and finish group, excuse me, as was picked up about the voice of the children and young people, the professionals that are working with speech and language therapy and interacting with that service, and obviously the adults too. It was about the voice of being heard, and the committee considering a task and finish group as a way to look at that in more detail and to hear about that user experience. So the suggestion and the recommendation, which I think is 5.2, I believe, is for such a group to be set up. If the committee agreed, then obviously it would operate over a defined period. It would gather evidence essentially as the proposal is in the paper, is on that user experience, looking at understanding the effect of any barriers or the positives of timely and effective therapy, and opportunities that are identified for improvement from those people. So it would be time limited with a view to having that scheduled in as a report back to this committee, and off the back of the discussion today, it would be good to tie that in with colleagues as a report back on an update from the services, so we could tie the two in
together so that we've got that service update, but we can also see what recommendations could come out of listening to the service users and professionals, both in the children and young person space and in the adult space also. So that's where the recommendation sits. Obviously, if there's a proposal to widen the scope of that, then obviously members are able to propose that as an amendment to 5.2 recommendation. Hopefully that's clear. Thank you, Chair.
Lucy Galvin, did you want to add anything to the point at 5.2?
I don't think so. I think that covers it really. I think possibly could we ask for the scope to be circulated so that we can kind of... does the scope have to be completely agreed now at this point, or could it be circulated before the task and finish group set up to be adjusted if we think? And I'd also be interested to hear from colleagues what they'd find particularly useful for that group to look at, for example, so that they could perhaps feed in a bit there. But I mean, it's potentially quite useful, a task and finish group, to make recommendations and work quite closely with officers on the work so that we can deliver something that's actually usable. Does that help?
I have been advised that we do need to set the parameters now, starting the task and finish group. Yes, of course.
Yes, obviously coming out of this committee meeting, if the recommendation is passed, the initial scope, which is set as looking for that feedback element from the service user, that would be the overarching scope. How the approach is determined would be part of the process that would go forward, but the scope would be limited to the feedback from service users, families and professionals, and that's what the task and finish group would look at, because any change to that would have to come back to this committee for agreement, so that work would be delayed until January for the group to go forward, which is why if there's any change to that recommendation, then this would be the place to amend that.
That seems fine to me, that the feedback, that scope's quite wide, isn't it, with all that feedback? So I think we can work well with that. Thank you.
Thank you. So committee, at this stage, could I ask if you're prepared to accept this proposal for a task and finish group? Those in favour, please raise your hands. Those not in favour? One. You don't need to explain why, honestly, but you can if you want. Fire away.
Yeah, if we're only going to consult with the service users, then I think you get an imbalance there, and you probably get the negative rather than any positives. So it sometimes doesn't work.
Yeah, it does say professionals, families and individuals. Okay, so the majority, your comments have been noted. So therefore we'll go ahead with this proposal. Okay? Right, the second one is a letter. Do you want, the first thing is, do you want a letter first? Those in favour of sending a letter immediately? 1, 2, 3, 1, 2, 3, 4, 5. Those in favour of sending a letter afterwards? 1, 2, 3, 4.
Is that in additional to the first, or is that instead
No,
of the first?
this is instead of the first. So we're going to have the first, afterwards, or both. So right now, we've got 5 in favour of first. Yes, I think so. 5 in favour of second. Who's in favour of 1 before and 1 after? Oh. I don't know what I'm doing. I need a proposer please, for the letter. Lucy Shires, I need a seconder, please. Peter Wilkinson, I need a vote generally to start with. Shall we do a letter? Okay, right. Now I'm going to ask Megan here to count the votes. Okay, so we're going to take this one more time.
I think we haven't agreed what the letter is, and I think that's probably why people are getting a little bit confused. So there's the one letter which is, please can we have a joined up approach for early years government, because it's causing too much confusion and it's not a narrowed enough vision. And then we're confusing that at the moment, I think, with writing to government about speech and language therapy, and we need a little bit of clarity on what letter we're actually voting on. I think that's why there's confusion from the room. Okay,
thank you. Lucy G.
So then I could, maybe it would be helpful to propose that we have that letter about the landscape, the current landscape now. That's one proposal. And then we have a second letter with the results of our task and finish group, if appropriate.
Yeah, and to make sure the important point which Rebecca brought up about a government policy, a joint policy from education and health, if we build the letter around that.
What she's talking about. So Becky, fire away.
No, don't apologise, absolutely not. What I was going to just put out there to the committee is that the request around, which was specifically made about the current landscape, what I was going to suggest in the first instance, that information might be out there and there might be studies or papers that are available. So assuming that it's not, it will be included in the letter. But if there is information that fills that space, which I'm thinking there isn't because of the request, I'll make sure that committee members get that as part of a briefing note. So I just wanted to say that. So we've got essentially those two parts to the letter, and working out which department to send it is probably a letter in itself. So, yeah, so we've got the issue which is about the joined up approach to policy making that Rebecca and, Karen, have made about that joined up cross-government departmental approach to policy making and that wider point around that. Then we've got looking into the issues of why the referrals are getting increasing in general, and obviously looking at the information and what work is being done to address that. So they're the 2 points I've got on that letter that would be going out following this meeting if agreed. What I would suggest is that you may not want to suggest a letter after the task and finish group, because there might not be anything that you want to write about, and then you'll just be a pen pal. So my suggestion would be that we move forward with a letter specifically on those two issues, or anything else the committee wants to pick up, and then we can revisit if there's an appropriate letter that needs to come out of that working group.
Are you happy with that? Good. What I'll do then is I need to take a vote. I don't need a proposer and a seconder, do I? Okay, everybody vote now, please. We're all in favour, I think. Yes, thank you very much. My suggestion is that we work on the letter, we get it to you as soon as possible for comments, please. Could I ask for a really, really rapid turnaround on the comments, and then we can get this sent off? Is this okay? Okay. So we know where we are, we know who we're writing to and when we're writing and what we're writing about, and we're going to have a task and finish group. Is that it? Okay, lovely. Thank you very much. Thank you. Oh, no, Karen.
Oh, I'm so sorry. I was just wondering if there was a timeline around that task and finish group. Oh, we work on that. Okay, because I want it to feed into the review. That would be very helpful. Thank you very much.
Yeah. It will be fast. Yeah. but we'll let you know. Okay, I'd like to thank those of you that have come today to speak to us. Thank you, and thank you for fielding questions. So that ends this part of the meeting. So we're now going to move on to the Forward Work Programme. So I'll give you a chance to leave, unless, of course, you want to stay.
Thank you.
We're just holding the meeting just for a couple of minutes. If anybody wants a comfort break, literally go and come back. Just 2 minutes, okay. Some people needed an adjustment. Thank you. We're moving on now to the Forward Work Programme, and Becky is going to explain it to us, and then I have a lengthy letter to read to you. Thank you.
Thank you, Chair. So the Forward Work Programme and the report are obviously there for you to see. Just to explain some updates to the work programme, the weekend pathology testing was included in the briefing that was circulated to members, and off the back of that there's been several members have questioned that. So the proposal is to bring that as a formal report to the committee in January. So that's a slight change on the Forward Work Programme. And then we have, you'll see that I've put 2 items at the bottom for the December briefing note, which pick up on some points that were raised in general at the last meeting, which were regarding patient satisfaction and also the sort of working with the voluntary and community sector. So just some background information for yourselves. There may be other items obviously to be included in that briefing, but that's just to update you on that situation. Just another part for the committee to note, at their meeting of the 18th of September, Norwich City Council Scrutiny Committee resolved to ask the Norfolk Health Overview Select Committee to scrutinise the ICB specification of the Vulnerable Adult Service openly in open session due to the health impact changes that would have on the city. So Councillor Jones and I have spoken with ICB colleagues to provide the committee with clarification on the issue of the Vulnerable Adult Service. Unfortunately, the executive directors couldn't be here today, so what they have is they've provided the chair with a statement regarding the Vulnerable Adult Service. So I'll pass over to Councillor Jones to read the statement out to yourselves regarding that service. So over to you, Chair.
Okay, bear with me. So, they want to thank members of the committee for their interest in this matter and say it's really important that we continue to take action to support people from inclusion health groups. In summary, our approach to this procurement has been to change very little in the service specification. We value the current service and we are committed to re-procuring specialist support. As members of the committee will have noted, specialist legal advice has confirmed there was no material change to the specification. Our expectation is that where we have added new elements to the specification, this will improve outcomes and value for money. We want to make it easier for people to access the service. At the moment, before people can get support from the service, they have to register with the Norwich Health Centre first. We're changing this so that new patients won't have to move their registration to the health centre unless they want to. They could instead stay registered with their existing GP practice. It's worth noting that the Vulnerable Adult Service is not a standalone GP practice and cannot register patients. So even though people's care is provided by the specialist service at their base, as mentioned, all the people that currently use the service have to register with the Norwich Health Centre. We know that each patient is an individual and should be treated as such. We would expect the professionals providing the service to make clinical judgment regarding the transfer of care in order to ensure it is appropriate and safe for each individual. We have put 6 weeks or as appropriate in the service specification because we anticipate that for some individuals, the 6 weeks may need to be flexed in response to their circumstances and needs. The specification for the current service includes step-up and step-down aspects, with patients being able to access services at their GP practice, the walk-in centre and other NHS services, whilst also getting additional support from the Vulnerable Adult Service as required. This won't change. We will work with the provider to ensure standard operating procedures and clinical governance are in place to ensure safe clinical practice. One change we have made to the specification is to add in a requirement for the service provider to help upskill the wider general practice workforce. This will help to ensure there is a consistency of approach between professionals when treating people, support really good dual care, and ensure the step up, step down between services works smoothly. We hope this provides the committee with further reassurance that we are not proposing to make significant changes to the service. There will continue to be a specialist service in place working with the general practice and others as it always has done so. People using the service will be registered with the Norwich Health Centre or another GP practice going forward. But as is the case now, they will be treated by specialists. And, as is the case now, people's care will continue to be tailored to their specific needs as it should be. And that was from Chris Williams, Head of Communications and Engagement, NHS, Norfolk and Waveney ICB. Hang on a second. Okay, so I have to advise the committee of the following. I see your hand. The statement will be circulated to the committee members and will be appended to the minutes of this meeting. Subject to the committee's agreement, the Chair will ask Becky to liaise with the ICB to confirm when a report on the Vulnerable Adult Service can be brought to the committee at the earliest opportunity following the conclusion of the procurement process, and this will be communicated to the committee once confirmed. If this approach is agreed, Becky will relay this back to Norwich City Council to feed to their scrutiny committee. So at this stage, I have to ask members, do you support this approach, and can you do it through a show of hands, please? I need to do this first, and then you can... I need to ask, this is the advice I've been given. I have to go through it in this way. Can I ask you, please, are you prepared to accept this through a show of hands, please? Can you count the numbers for me? You?
Just unhappy with one tiny clause in that.
Yeah, okay.
So 7.
7. Yeah, so we've got 7 people agreeing with it. Okay. Okay, go ahead, please. Yeah.
Thank you. I'm not quite sure about the process there because obviously I'd have liked to have said something about this, and the what you read out was the same as what's come in a letter from Ed Garrett that's gone to all members as well. So having it read out by Ed Garrett as well as going in read out by you as well as going a letter from Ed Garrett seems a bit odd as a process, but never mind, maybe people need to hear it a few times. I think as well as hearing a few times what the ICB say, which is great, but you know, we also need to be able to ask questions ourselves and be able to question the ICB. So I do have further questions on that it would be good for members to have known that. And I will share those. And I've asked for sight of the written evidence provided by the ICB to their legal advisors on which they based the decision that there was no material change to the service. Even in that letter that you just read out from them, that we've also got as an email, they say something like, there's no change, but the things we've added are, and it's like, well, which is it? Is there no change or have you added things? So there is a question around that, and I'm seeking that information as a member of HOSC, and I have sought that information, and I'll carry on seeking that information. So the VASTA service is relet in April, and there will be then an opportunity to collect data to pick up if there are any issues with any changes. Yeah, so from the patients and the staff involved. And I'd like to propose that we ask Healthwatch to help with this once it's relet, so that we have input into the scope of what they do, and that the work starts immediately in April, so that the checks are ongoing from the beginning of the change. That's because health inclusion is a regional and a national priority, because it's an area where people aren't listened to historically, and because Healthwatch have done really good work in that area. They've already done 2 looks into that practice, which have been really, really helpful. So they can repeat that basically, and we can build on it. Because those audiences that access this service, this healthcare service, are not necessarily easy to reach or, simple to talk to. So it needs to be done very carefully and sort of mindfully, because they're also very vulnerable. So what my worry is that work needs to start straight away from April. I can see that it's important that the service is commissioned and carries on, but it needs to be looked at. There is a question about whether it's a different service or not. The question does remain, despite things being read out, etc. The question is still there.
Can I just cut across you just for a minute?
Yeah.
The reason it was read out was that it would be public record.
Yes. Well,
So it has been made a public record now by me reading it out. The public didn't have access to stuff that was being sent to us before.
Okay, thank you. That's good to clarify. So for public record, from the point of view, I'll have some feedback on that letter, and I will then read that out at the next meeting. So that's in the public record as well, hopefully. But going back to that, my last point really was that investment in, the reason this service was set up was to save lives and to save money as well, because if people aren't looked after properly, these cases are very, very complex, and people end up in the wider services where they're not looked after adequately. They end up at hospital, and that's the problem, basically, to put it bluntly. So we've got a very, very good service that's been achieving very highly, which we want to carry on doing that. So any change, we don't want to have a detrimental impact, both on vulnerable people who need that service and on other patients and health practitioners across the county, frankly, who will be impacted badly if those very vulnerable people aren't looked after in the right way, in an effective way. So that's the important thing for us to look at. So I'd like to propose that we work with Healthwatch to do a check once the service starts, talking to staff, talking to patients, to repeat, and then that come back to us in a timely fashion. Because I have been asking for this scrutiny of this service for well over a year now from here, and it's taking a long time to get through. Thank you.
Thank you, Lucy. Yeah, I've just been advised that what we'll do is we'll go to Healthwatch and we'll discuss it with Healthwatch and then come back to the committee with that information. I think Becky's got some more stuff that she has to tell us.
Yeah, I just wanted to be clear about the role of the Health Overview Select Committee and its duty to consult, to refresh members' understanding of that. So The duty is placed on NHS providers to consult the Health Overview Select Committee on service changes, but it is for the provider to determine whether proposed changes have triggered that duty. It is not for the committee to determine that. In this particular instance, the ICB have not determined there is a duty to consult this committee, and therefore that is why they are not bringing that to this committee at that point in time. The recommendation or the way forward that you have passed is that I will liaise with the ICB to make sure at the moment the forward work programme has it as an item to be confirmed. I will work with the ICB to make sure that we've got that scheduled in for an actual meeting so you know that that is there and it will be scrutinised. And picking up the point about Health Watch, we can have conversations with Health Watch to see how... I don't know that we can tell Health Watch what to do, but we can certainly have a discussion about what that could look like and if they can be involved in that space, and then we can work together with them also. So I'm very happy to take that forward for the committee.
Okay. People happy? For future briefings, Councillor Shires.
Thank you. I have already spoken to you over email about this one, Chair. So I've been asked, which is how this should work, for us to look at the transition between children and adolescent mental health services and adult mental health services. We've talked a lot about transition today, and I think that's something that's important. We have looked at that before, and we did find that there was quite some gap, and the tell it once side of stories that we often hear from mental health clients, service users, is that when they have to repeat themselves, that's quite distressing. So we just need a little bit of work on that. And then the other thing that I really want to ask us to get some information on is, unfortunately, I've got a resident in my division whose father was due to be discharged from hospital almost 6 weeks ago. He's unfortunately got an MRSA infection and he's suffering from organ failure. And that's because there was no bed for him to be discharged into. And we've heard the issues with Benjamin Court being closed. And that would have been where his father would have gone to. So I would like this committee to get information on how many people are stuck in hospital that have been discharged but have got nowhere suitable to go on to. That would be useful to find out how long people are staying beyond their need, and also whether or not any infection rates of those patients are increasing. Because I think it's so distressing to know that he just wants his dad to be somewhere safe, and there was nowhere for him to go.
Oh, thank you. Thanks, Lucy. Yeah, that's very sad. Becky.
Yeah, obviously subject to the committee approval, we can explore those, you know, in their appropriate format. I would say that obviously intermediate care in the wider aspect is something, as you've highlighted Benjamin Court, so that that might be something that the committee want to sort of get an update on. Separate to obviously the specific issues about discharge delays and infections, so maybe add that to that, certainly as part of a briefing would be my suggestion. Thank you, Chair.
I think one thing that's highlighted today is really the importance of having proper details and proper statistics. It's going to cross the whole meeting that we actually need the details and not just some sort of fairly vague graphs with coloured in places. I know people mean well and they know what they're doing, but I think for the committee, we need for people to be more specific about figures and what's presented to the committee. Thank you. Jeanette, did you have something? Oh, I beg your pardon. Oh, sorry, was there agreement to that, please, by the committee? Yeah? Thank you. Okay, Lucy, please.
Thank you. Yeah, I'd like to propose that we schedule a further in-person meeting of the committee and to examine the Wellness on Wheels bus. I thank you for the information that was in our report. It was really useful. But I think for strategic oversight and integration, you know, how that's delivering, as it's a cross-sector initiative and it's aligned with the Health Inequalities Strategic Framework, the report doesn't quite demonstrate how it's fulfilling its duty to promote integration. It doesn't really demonstrate if it's part of a coordinated commissioning strategy or how the health data is being used. Also for some performance scrutiny accountability, we could usefully look at it. So I'd like to, and I can give you a few more details on that, I don't want to take up too much time, but there's quite a lot of questions that the report doesn't answer, which I think are very important, about impact, value for money, evidence base, and operational transparency, which I think we need to look into. And I'd like to recommend that we invite representatives from the ICB and relevant service providers to attend a dedicated session on that, which would allow us to kind of review the strategic alignment of the bus with system-wide priorities, examine performance data in detail, and make any recommendations necessary. I think it looks like that might work in quite well with a review they're doing from looking at the paper that you sent. So, I mean, you might need to go back to them and ask how that can be most useful, but I think it's necessary. So I'd like to propose it now.
Thanks, Lucy. Before it's proposed, I just need to check with Becky because Becky organises everything.
Yeah, I just wanted to highlight, as Councillor Galvin has pointed out, there is a review that's taking place, and that is looking at the sustainability and alignment of the service in line with system-wide priorities. So, subject to the outcome of that review, there may be changes to the service which would then have a knock-on impact on what could be brought to this committee. So once that review has been concluded, I would suggest that there would be recommendations from that, and once they are known, we could circulate them, and then a report could be brought off the back of that to explore what that proposal is. What I'm conscious of is that if the service is there, it's being reviewed, and there's any change to that, what the committee is doing is it's looking back and it's not actually scrutinising the future development of that. So it's for the committee to determine, but I just wanted to sort of highlight that as a just to sort of guide any report and committee use of resource. Thank you, Chair.
Would you be satisfied with that, Lucy?
Yeah, could I ask just a question about the timescales and the parameters of the review, because there's not much information on that. So I wouldn't want to sort of kick it into the long grass, if you like, with the review that I don't know, you know, when it's reporting, what it is, and if we'll see it.
So what I could do as part of December's briefing is I could ask for a detailed brief on that review for members, so that you could see exactly, like you've said, what those parameters are, what it is that they're looking at. You're right, it refers to it, but not in detail, which doesn't really give you that knowledge base to make a decision on. So that could be a way that we could get that information, and then members could reflect on that. So that's a consideration.
Thank you, that's really helpful. And I would just reiterate, there really isn't enough data. We really don't know it. And I think as a Health and Scrutiny Committee, we really do need to look at this. So that's fine, December, but then I think we really do need to look at what's happening there, because it's quite a costly service, you know.
I've got two people indicating they want to talk. Is it about this service or is it about other? Peter wants to talk about this service, and then we'll take Lucy afterwards.
Yeah,
other Lucy.
Good point brought up in the sustainability of what Becky was saying, and I think facts and figures ought to come. If it's relieving a bit of pressure on the local doctor surgeries in each town it turns up at. That I think that'd be very important figures and would help with rebuilding and taking it forward sustainably.
Okay then, are we having to vote on anything at this stage? Can you just agree then that we will be looking at this in January? Yes?
Agreed. I'll put it in the briefing note for
Yeah.
December, and then we'll review it as part of the forward work programme.
Okay, so it's going to be in a briefing note, and then it will come before the forward work programme in January. Okay, is everybody happy? We'll have more information then. Okay, thank you. Right, Pallavi.
Thank you, Chair. I just want to ask about a couple of items that seem to have slipped off the forward work programme. One was the new hospital programme, the build. I'm specifically concerned about the QEH, but I understand it's been clubbed together with the James Paget now.
Further topics.
Oh, I see, it's in further topics. I missed that bit. Okay. Right. Do we have a timeline for that? I mean, it's...
Yeah.
Yes, please.
Yep. So as members will see, there is information included on in there on the new hospital programme, and it's for updates to be provided as and when information is available. Obviously, we've had recent changes and announcements, so I can see if there's anything that we can put in the next briefing note if we've got updates on that new hospital programme. So I'm happy to chase that and see if we can provide information to the committee for December.
Thank you, Becky. I think there's just been a general... people have been disconcerted at the way the three trusts have started to work together without any public awareness or consultation. It's almost as if they just went ahead and did it. Nobody was made aware. Pardon?
I think Peter will agree as a governor. It was very last minute that we knew as well.
And that's shocking. You know, that should never happen. So I don't know what the answer is, but I'm just dismayed, and it doesn't fill me with trust or confidence, the way they're going about this whole, amalgamation of the trusts.
I mean, I can't answer that, but what I can say is obviously one of the actions that we were looking to bring forward for the committee was an update from the hospital group in the future on how that's worked. So obviously the chair has conversations with Leslie Dwyer, so it might be appropriate that the chair feed that back. But it is certainly on the forward work programme for the committee to see how that new hospital group is functioning and performing within a good period of time to have data to reflect back on.
Thank you. If I may, just one more thing, Chair. Sorry. Only to say we have this the item about the weekend pathology testing. Without wishing to dilute that, because that's clearly very important, I wondered if we could actually broaden the scope of that to look at pathology services, so blood sciences, to also look at the points that were raised today, which the operations person said he'd take away and look at. Just look at, hopefully, challenging or asking Norwich and Cambridge to work together to have some sort of integration and collaborative working, so that our patients are not disadvantaged.
Do members agree that we would broaden the scope? General agreement? Yeah. Okay, thank you. We'll do that. Lucy Shires, then Jeanette MacDonald, and then Justin Cook.
Just one that I don't know if it should come to us, but I feel like it should. The wellbeing hubs that were introduced across the county to support mental health, primarily to support in community needed mental health services, but to reduce the amount of people who were ending up in our A&E departments in mental health crisis. I think we are now in the third year of the final one opening, which was the Elsham one. I don't think we've had any information come through on there, but they are all NHS funded. So it would be helpful to know whether or not that's having any impact on the numbers we're seeing in secondary care or indeed crisis presentations at A&E.
So if we ask for that as a report, it would be handy to have that before March when we've got an SFT here. Yeah, or Becky's saying we could get a briefing, so that would be good.
Yeah, it was funded by the CCG, so I don't think it sat with NSFT. Obviously, the CCG is some time ago because it's the ICB version 2.
Yeah. Okay, thank you. Do we agree with that one? Yeah, okay. Who did I say next? Justin. Oh, no, Jeanette.
I did flag this some time ago, but I think it has completely fallen off the radar. And these were the over 40s health checks. Again, another really expensive, from what I understand, initiative across the country. I don't believe it's commissioned by the ICB. It's Public Health England or County Council. But, you know, these people are all over the place like a rash, in libraries, in our hospitals where nurses could carry them out. And it infuriates me because this is a private company that's doing it. Reed, yeah, who are better known for training services. And very few of the people carrying out the health checks are health professionals. I just see it as a complete waste of money.
Becky has news on it.
Make it. I earlier this week got some information about the over 40s health checks, which came from the Norfolk County-wide Community Safety Scrutiny Subpanel meeting last week. So I'm happy to share that in the first instance with members. And include that for information. If it's not quite what I think the committee is looking for, then obviously I can go back and ask for something else. But I do have some information about those health checks that came in this week to me, which I can share.
Thank you.
Is the committee happy that this is shared with you and then we can consider that at the next meeting? Thank you. And the next person is Justin.
Yes, I've also raised this a couple of times as well. The lack of the actual people on the receiving end of care's voice within the room. I think we quite often have the people here and they're talking about it. We ask them questions and go, how are you evidencing that? How are you providing us with the assurances that patients aren't impacted or people using your service? Often they're not here. So we don't get to hear the outcomes. So I would really like if there was a way within all of our programmes, if there was a way of getting that from the people presenting the reports. Because again, we saw today, we had to say, what is the evidence? How are people being impacted? I think that's just missing throughout this, but I know we have limitations within our role.
Yeah, thank you. I know Becky's going to come back on that because she comes back on everything. But I totally agree with you. I think if we don't hear the voices of the people who it affects, I think that's a very valid point. And it's also, you're only getting one side. And although I'm fairly sure people are honest and sincere in what they're saying, you need the other perspective. Jeanette, your light's still on. Charging you for that.
Yeah, thank you, Councillor Court. You're absolutely right. And obviously, it's, there's resource limitations as to how we can reach out into the reports, but certainly happy to take that feedback on and be more conscious of it for future reports.
Anybody else? Okay then, the date and time of the next meeting is... When is it? When is it? It's on your paper. It's on my paper. Show me. I'm so sorry. 15th of January. 15th of January, 10 o'clock. Have a happy Christmas. Bye.